Dr. Raksha.
Good evening, all viewers. Today's webinar is brought to you by Artist, which expands as Asian Research and Training Institute for Skill Transfer. It is a premium institute based from Bangalore. I am Dr. Raksha Suvarna, working as a researcher and master trainer at Artist. It's our privilege today to welcome our international speaker, Professor Caroline from Australia, and our distinguished panelists, Dr. Alka Kriplani, Dr. Prakash Trivedi, Dr. Madhuri Patil, and Dr. Vidya Bhatt. Session is on endometriosis, Enigma Prevails. The session is moderated by Dr. Hema Divakar, who is a CEO and chairman of Artist, who has conceptualized a series of knowledge cafe on cutting-edge topic, which will be unveiled in the coming months. Over to you, ma'am. Thank you.
Thank you very much, Raksha, and welcome everyone once again. There's already a poll put up there on your screen because we want to know whether you're attending this webinar just because you have plenty of time in the COVID pandemic and you're at home doing nothing, or are you keen on translating some of the lessons learned from our experts and the insights and practical tips given by them to translate it into your practice, that being the whole purpose of the Knowledge Cafe, because we believe that a lot can happen over coffee. So once again, on my own behalf, extending a very, very warm welcome to all of you and to our very beloved guests on this session on Knowledge Cafe on endometriosis, the continuing Enigma. They have a lot to offer with decades of experience, and the issue of endometriosis, there is nothing standardized. It is so individualized that the mix and match, the pros and cons, the risks and benefits of doing one thing as against the other is going to be a very meaningful deliberations with such a stalwart of experienced guests that we have on our show today. So without much ado, we will invite Dr. Madhuri Patil, who has been responsible for bringing our very distinguished guests from Australia. Beyond the geographies, we are making history today with the deliberation from Dr. Caroline Garrett. May I ask Dr. Madhuri Patil to introduce our guests, please?
Good evening, everybody, today, and I'm sure you would enjoy this webinar on endometriosis. It's my great pleasure in introducing Professor Caroline Garrett, whom I met almost 10 years ago in Spain, and I was totally impressed by her research on endometrial stem cells and endometriosis. She's professor at the Ritchie Center of Hudson Institute of Medical Research in the Department of Obstetrics and Gynecology, Monash University. She is also at the National Health and Medical Research Council, where she is a leadership fellow. She heads the Women's Health team at the Ritchie Center. She leads the endometrial stem cell biology group. She's received several national and international awards for her research from the Society for Reproductive Investigation President's Achievement Award in 2013. And in 2011, she's received the award, the Endometriosis Foundation of America, for her pioneering research in endometriosis. Professor Caroline, please. Can you share your slides, Caroline?
You have to unmute yourself as well, Caroline.
Yep. Okay. And then Zoom. All right. Okay. I should be able to begin. Is it okay?
Yes.
Yes.
See? Good. Okay. Well, firstly, I'd like to thank Madhuri for a very kind invitation to speak to you in your Artist Knowledge Cafe webinar this evening. and I'm going to talk to you about new concepts in the etiology of endometriosis. But I'm actually going to start with some old concepts, the concept of retrograde menstruation as a cause of endometriosis, and bring in some new ideas that have been developing over the last few years that extend that hypothesis, and perhaps will end up really shedding some light on what the cause of endometriosis really is. So retrograde menstruation is a physiological process. It actually transports the menstrual products into the pelvic cavity. And this process has been identified by transvaginal ultrasound and pressure catheter recordings, like a catheter inserted into the uterus. And what some of these have found, and here's a transvaginal ultrasound, which looks at innermyometrial waves. There's that unit, there's the innermost layer of the myometrium that's right against the endometrium is comprised of circular smooth muscle cells, very responsive to estrogen and progesterone. And in studies using this transvaginal ultrasound, they've found cervical fundal endometrial waves during menstruation, and in 88% of women with endometriosis versus 5% of controls. And a second type of examination of contractions and uterine contractions that might propel the menstrual products into the pelvic cavity, they've looked also at uterine contractions, and these contractions involve the outermost layer of the myometrium, and they're the longitudinal fibres. They're not of Malurian origin, and these contractions, and they don't really respond to the hormones in the non-pregnant uterus, but these studies have shown that there's a 2 to 3-fold increase in the frequency, the amplitude, and the uterine pressure in women with endometriosis, suggesting perhaps there are some differences in the process of getting that menstrual debris into the pelvic cavity. But these are not very easy approaches to use for clinicians in their rooms. A future approach might be to use transabdominal electrohysterography, which actually looks at the electrical activity of the uterus, and this has been looked at in pregnancy and monitoring contractions. But you'll see here from the colours on these heat maps, the red is like high intensity, the contractions that are moving through the uterus looking like they're going towards the fallopian tubes. So retrograde menstruation is an active process. It may be abnormal in women with endometriosis, but it delivers the products of menstruation into the pelvic cavity, and in those products must be the cells of origin of endometriosis. And I'll talk about, something's gone wrong here. Sorry, my screen is doing, hang on. Okay, sorry. So this is my summary slide of what I'm going to talk about, but I'm going to talk about retrograde menstruation. We know that in all ovulatory women you see blood in the pelvic cavity during menstruation, but only really 10% develop endometriosis. So the etiology is multifactorial, and I've just talked about these abnormal cervical fundal contractions during menses. I'm going to talk about endometrial stem progenitor cells in retrograde menstruation, a little bit about neonatal uterine bleeding. I'll talk about the genetics quite a bit because there's a lot of new knowledge in this area. And finally, there's a lot of interaction between the genetics and the inflammatory and the environment. And so it is a multifactorial, enigmatic disease, as you've all talked about already this evening. So to go back to the cells, the stem progenitor cells, which we think would be the origin of endometriosis. And when we wanted to look at this, we actually had to discover these cells to begin with. And we discovered them as clonogenic or colony-forming unit cells. And how we did this is we took hysterectomy tissue, took all the endometrium and made it into single-cell suspensions, and then we put the cells at very low density on these culture plates. And you can see all these little clones of cells that have grown up. They've been initiated by a single cell. Most cells can't do this. And so you can see that the epithelial clones were only 0.2% of the cells and stromal ones 1.3%. So these are the cells that are capable, if they're transported somewhere else, to initiate a growth of endometrial cells. We then looked at their adult stem cell properties, and we looked at self-renewal by just serially cloning these cells at very low seeding densities to see, and showed they had considerable activity in that property. They also have high proliferative potential. A single cell from starting up one of these clones can actually produce about several billion cells. This is huge output, and that's about 30 population doublings worth. And then when we looked at the differentiation capacity, we took one of these epithelial clones here and we cultured them in a three-dimensional organoid type culture, and we got these large gland-like structures from those. And when we took an individual large stromal clone and cultured it and divided it into four and put them in medium that would induce them down the smooth muscle, the bone, the fat and the cartilage lineages, we could differentiate them down all these mesodermal lineages. And this told us that human endometrium contains a rare epithelial progenitor cell population and mesenchymal stem cells. Now, this is all very good because it told us there was stem cell activity in human endometrium, but it told us nothing about the cell types themselves. We didn't have any idea what their identity was, where they would be found. So our next job was to find some markers, and to be practical and useful, they had to be surface markers so we could isolate the cells. What we did, this is a flow cytometry plot, but we just tried lots of different markers that we knew were out in the field of mesenchymal stem cells and put them together. And this little population here of expressing both these markers, we tested them as well. Any marker we tried, we had to test, did it pick up the endometrial stem cell activity? And you can see here that we did our clonogenic or CFU assay. All the cells in this little population of 1.5% were clonogenic. Okay, so this was our readout. And then we could look in the tissue and we found that the cells, which were yellow here, so co-localizing both those markers, are around the blood vessels. And in fact, they're very close to the endothelial cells. Now, having two markers and using flow cytometry like that is not a very practical way of going about things. So because they are perivascular cells, we screened then for perivascular markers. And this one here called SUST2 isolated a small population of cells. And then when we looked in endometrium, we could see that they're red staining here. You could see that they are around spiral arterioles and veins, sometimes co-expressing smooth muscle markers. So when we look at endometrium in a schematic here, these endometrial EMSCs are around blood vessels. They're in the basalis where we thought they would be, but they're also in the functionalis layer that's shed during menstruation. And so this is really important when we're thinking about the concept of endometriosis. Now, when we came to find a marker for the epithelial progenitor cells, which are much more difficult to work with, we went to an unbiased gene profiling approach. And what we did here is we decided to compare highly purified populations of epithelial cells from postmenopausal endometrium with premenopausal endometrium. And our reasoning was that in postmenopausal endometrium, we thought that atrophic endometrium would be a bit like the basalis. It can respond to estrogen when it's there. And then we thought that the cycling endometrium would be so thick with functionalis that we would see differential gene expression away from the basalis. And so then we had to look for surface markers. We found 22 in this heat map. but then the positive ones or upregulation is in red, and we needed it to be high in postmenopause so that it was positive, we could isolate the cells. And this is the marker we chose, which tested several actually, but this is the one that really worked in our cloning assays. So CDH2 is the gene for N-cadherin. It's a surface marker, and you can see here that there's lots of large clones as opposed to the negative population, which is the majority of the cells. That we hardly got any clones, and they were not really dense like this one. And we did all those properties I just showed you before of adult stem cells, and were able to grow even glands with lumens in them in the culture dish. Then we had a look at where these cells were located. And as you can see here, they're all stained in red, the N-cadherin. They're the epithelial cells in the very bases of the glands, right next to the myometrium. And because N-cadherin is a epithelial mesenchymal transition marker, it's important in cancer, we had a look to see whether this might be the case. And we just looked at E-cadherin, which is an epithelial marker. And you can see the co-localization here of the two markers. It's yellowish orange. And because these cells right at the bases of the glands were expressing both E and N-cadherin, we kind of figured that they weren't going through EMT, that's just what the cells were expressing. We looked at estrogen receptors, and again, you can see that they were present in our N-cadherin positive cells. Then we looked at another marker that had recently been identified of the collaborator called SSCA1. This marker enriches for cells rich in telomerase, and it's located in the basalis. But when you have a look at where the N-cadherin is, they didn't really overlap very much, and the N-cadherin ones were always closer or deeper than the SSCA1. And from this data, we have made the conclusion that there's an epithelial hierarchy in human endometrium. And, you know, the glands are just lined by a simple columnar epithelium, but they obviously have different properties. And right down here in the deepest bases, where they're just N-cadherin positive and SSCA1 negative, they're the clonogenic cells with the adult stem cell properties. Then there is a small little area sometimes where there's overlap, where both markers are expressed, so maybe they're a little bit maturer. And then there's these green cells, which are the N-cadherin negative, but SSCA1 positive. And we think that they're located on that nebulous boundary between the basalis and the functionalis. And when the endometrium shed during menstruation, these green SSCA1 cells come out of the stumps of the glands, and we believe that they will resurface the epithelium, the endometrium, so that when it grows during the proliferative stage, those green SSCA1 cells form the luminal epithelium, and they also express SSCA1. Then the majority of the cells are those white cells in the functionalis that are the mature endometrial epithelial cells. Okay, so having those two markers meant that we could now, and having determined stem cell activity, we could now look at their role in retrograde menstruation. And so we developed this hypothesis. It's a two-stem progenitor cell hypothesis, so two cell types. The endometrial epithelial progenitors and the mesenchymal stem cells would be shed in the menstrual fluid by retrograde menstruation, through perhaps some of those mechanisms I talked about earlier. They're shed into the pelvic cavity to establish where they adhere and establish endometriosis lesions. And we think both cell types are important and required. So this is just a slide of that data. And what we did here is we collected menstrual fluid and peritoneal fluid from women on day 2 of their menstrual period, having a laparoscopy. This was logistically quite hard to do. Anyway, with surgeons who would help us. So here's the N-cadherin. I've got this little schematic here to remind you of what we've just been talking about. N-cadherin, remember, are the red cells at the bottom here. and the SUSD2 cells are the cells around the blood vessels. So when we looked at normal controls, we found that they were shed in menstrual fluid as we would expect, and same with endometriosis. The N-cadherin positive cells were shed in menstrual fluid in both controls and endometriosis women, but not all of them, so some didn't, okay, which is what you might expect. There's no difference. And likewise with SUSD2 positive cells, we found in menstrual fluid that they were, these cells were shed in both control and endometriosis at the same amount, okay, but always present, and not surprising because they are up in the functionalis. Now, when we looked at peritoneal fluid, on the other hand, there was a lot fewer cells, endometrial cells, on day 2. For N-cadherin and looking at controls, you can see we haven't got very many numbers here, but we only had one woman who had, normal person who had a control who had N-cadherin positive cells in her peritoneal fluid, whereas the rest didn't. So about 25% of these women may have shed N-cadherin cells into the peritoneal fluid. But when you look at the endometriosis women, you'll see that there's 6 out of 10. So 60% of them had N-cadherin positive epithelial progenitors in the peritoneal fluid during menstruation. And this is the median concentration, 195 per mil. When we looked at the SUSD2 positive cells we in the peritoneal fluid, we did also find that more control women, about 4 out of the 9 that we tested, so about 45%, shed the SUSD2 positive mesenchymal stem cells into the pelvic cavity. But when you look at the endometriosis, where we tested a few more, but we had 10 out of 13, so this is about 67%, and the median is 230 cells per mil. Now, none of this is significant because our numbers are not high enough, but the trend is there, and it looks to us that there's an apparent increase in SUSD2 EMSC and an apparent increase in N-cadherin epithelial progenitors in the peritoneal fluid of menstruating women with endometriosis compared to controls. So that's where we've got with that area of work. But I just wanted to mention a little bit about early onset endometriosis and neonatal uterine bleeding. As the clinician, as the gynecologist in the audience know, that the early onset is often quite severe and progressive. It's usually peritoneal disease and endometrioma. And the concept is that neonatal uterine bleeding that occurs only really, it's overt in about 5% of baby girls, but occult in quite a lot more, and it all occurs during the first week of life. It's thought to occur because maternal progesterone that's been circulating in the fetal circulation is suddenly lost when the baby is born, and in a significant number, about 33%, of the neonatal endometrium has shown secretory and decidual and menstrual features at birth. And so we think that perhaps that drop in progesterone, or maternal progesterone, leads to this first menses. And so this is the concept here in a schematic. This just shows you a gross specimen of a neonatal uterus. It's predominantly cervix, which is functionally blocked with mucus. There's a little tiny endometrium. You can see decidual-like changes and even some shedding here, where some of it's quite mature. And so we think then, because of that blocking, that some of it is shed back into the pelvic cavity. These cells are quite potent. They would, we hypothesize that they would invade, like we can show in vitro, in under the mesothelial lining, and there they lie quiescent and dormant until telechy and menarche or puberty. And there's a precedence for dormancy of endometrial stem cells. And this is postmenopausal endometrium. It too is dormant. Is quiescent and doesn't do anything. But if you give postmenopausal women estrogen, you can regrow the endometrium. So they must have the progenitor and mesenchymal stem cells there in order to do so when they see estrogen again. So that's what we're hypothesizing happens here. And so as the estrogen levels start to rise in these prepubertal girls, then the endometriosis, the progenitor cells start to grow, form an endometriosis lesion. They may burst into the peritoneal cavity, but there's probably much of it is also sub mesothelium and produce the endometriotic lesions. So we think that neonatal uterine bleeding could seed the pelvic cavity with these potent stem cells to establish those lesions. Now I want to talk about the genetics of endometriosis or the heritability. And as most of you gynecologists would know, that it does seem to run in families, and the mothers and sisters with endometriosis, they have a 7 times increase incidence over the other population where there is no familial disease. Twin studies show a heritability of 50%. And the inheritance is complex because this is a common chronic disorder. It involves not a single gene, but many genes. It's a polygenic disorder. But it's not the only thing. It's multifactorial, and there's an interplay with the environment, with the genetics, and I'm going to just briefly talk about some of that. So the endometriosis risk genes have been identified by these large genome-wide association studies. They look at individual SNPs or mutations on the DNA itself. And these are massive studies, and you can see using massive numbers of cases and controls. They're big consortiums where they share all their samples. And in these studies, they've now found 27 genomic regions, and you can see them across the chromosomes at the bottom where they've been annotated. And these are robustly associated with endometriosis with high p-values. This shows this polygenic disorder, and it shows that there's many SNPs that are contributing each a little small amount to endometriosis risk. However, these studies have shown that the effect is much more or greater in severe cases. The interesting thing is that these regions that have been found with these SNPs are in they're in the predominantly non-coding areas of the genome. And so these are areas that are involved in gene regulation rather than an individual gene. And these areas then influence the transcriptional output of the genes in that region. And I just want to illustrate that here. So 2 endometriosis risk genes are found on chromosome 6, 25, and they are very near the estrogen receptor alpha gene, okay? And they're just listed here. And those 2 genes are also associated with breast, ovarian, and endometrial cancer risk. These are all estrogen-dependent disorders or hormone-dependent disorders. Other SNPs have been found in estrogen-regulated genes, in genes involved in the pituitary, ovarian axis, like polystatin, FSH, and proliferation genes, and so they're over here, and angiogenesis genes, and they all have roles, as you can imagine, in endometriosis. And mapping the expression of these in endometrial tissue has identified some of these genes, but not all of them. This one didn't show up in endometrial tissue, but some of them have. So candidate genes from different genomic regions are involved in linked pathways associated with estrogen-mediated endometrial cellular responses. But the thing about all these GWAS SNPs and risk variants, we actually really do need to determine their functional effects and work out which cell types they're involved in. And this is one of the things that we've just been starting to do. Now, another really recent and exciting finding are somatic mutations in the epithelial cells of endometriosis lesions and in utopic endometrium. These somatic mutations are not inherited. They arise through errors in DNA synthesis during cell division, and they're identified in genome-wide exome sequencing. So these are looking just at the coding DNA. So these will affect genes in purified epithelium. There's been 4 studies now that have shown, these are all high profile, and non-synonymous single nucleotide variations, or SNPs. Non-synonymous means that they will change the amino acid. Just this one base change in the DNA will change the amino acid, and it could change the protein too and its function. These have been found in the utopic endometrium. They've been found in deep infiltrating and endometriomas. But really interestingly, they've been found in the normal endometrium of fertile women. Okay, so other interesting facts are that the somatic mutation rate is quite similar to common malignancies. Some of the single nucleotide variations are cancer driver genes that have been were identified in deep infiltrating endometriosis in 26% of cases. They have quite low mean allele frequencies, about 20%. The cancer driver mutations are oncogenes, some of them, KRAS, PI3 kinase, etc. And the KRAS mutations seem to be the more common ones, have been identified in 4 to 38% of epithelial cells in each deep infiltrating endometriosis lesion. In this study by Suda et al., which is really interesting, they looked in the utopic endometrium and they isolated in 100 individual glands, and they looked at the mutations in there, and then they compared it. So what they found is each gland had its own unique set of mutations, and the lesions also shared the same mutations, but some of them had unique ones as well. So it looks like they had progressed further. And then these were all endometriomas, and some of them had ovarian cancer driver mutations, like the KRAS and PI3 kinase that I mentioned before. But the ARID1A cancer driver was only in the endometriomas. So what we think is happening here is that and they also found that the lesions in multiple sites had similar mutations to utopic glands. And so it looks like that it's spread around the pelvic cavity during menstruation, that the mean allele frequency was particularly associated with ovarian endometriosis, the KRAS, the PI3 kinase mutations, which if they're in these epithelial cells, will give us gain of function, particularly a proliferative advantage, so that when they do land in the pelvic cavity, those cells have got the advantage to, grow. So retrograde menstruation of endometrial epithelial cells with cancer-associated mutations have a selective advantage at the ectopic site in the development of endometriosis. We also know that not much endometriosis goes on to form endometrial or ovarian cancer, but all the same, these same driver genes seem to be involved. These studies also have come up with a 2-cell hypothesis for endometriosis lesion development, that clonal epithelium bearing these cancer-associated mutations and niche cells, the stromal cells that don't have these mutations, we think that EMSC would be important there for the angiogenesis. So there's two cell hypothesis, our stem cell one and the ones from the somatic mutations, and I think we can bring them together. Oops. Oh dear. Sorry, I think things have gone a bit strange. Oh yeah, okay. Okay. All right. Now I want to just look at another form of genetics, and these are epigenetic changes. And this is where the microenvironment comes in, and environmental effects that alter the gene transcription. What they do actually is alter the chromatin, and they open or close the chromatin, remodeling it, and this alters the DNA accessibility to things like transcription factors, and that alters gene expression. So there's 2 main types that have been investigated, or 3. DNA methylation, so when the DNA is not methylated or hypomethylated, the chromatin is open and it can transcription factors can bind. And that's mediated by these types of enzymes. When the histones, which are proteins that the DNA is wrapped around, so it can be so condensed, when they're acetylated, then that chromatin is open, and that allows the transcription factor entry as well. And that is modulated too by enzymes. And then there's these small micro RNAs, which I'll briefly talk about at the end. So environmental factors really do affect this epigenetics, and that's estrogen, local estrogen production, pro-inflammatory cytokines, and things like hypoxic stress. So these have been studied and have been definitely shown to affect the stromal cells, and we're hypothesizing the perivascular cells as well. The ectopic endometrium with DNA methylation has DNA methylation abnormalities or epigenetic changes that alter gene expression and do affect progesterone resistance, which is one of the features of endometriosis. In another one of these big genome-wide studies looking at endometriosis versus normal endometrial stroma, they found 47,000 different methylated CPGs. That's what gets methylated in various genes. And again, there was some intergenic DNA that was also differentially methylated or non-coding. 403 genes were differentially methylated, and some of them included transcription factors like the HOX genes, some of the GATA genes, nuclear receptors, and you'll be familiar with estrogen receptor beta, steroidogenic factor 1, estrogen receptor alpha, and progesterone receptor. And many of the genes are involved actually in decidualization and steroid metabolism and inflammation. So we're thinking that retrograde shedding of epigenetically abnormal stromal populations may establish the stromal compartment of endometriotic lesions. Now, this is probably the most difficult slide I've got for you, but I think it helps to explain what epigenetics does and how it alters the gene expression in the endometrium and influences the phenotype that you're seeing in the clinic. So master regulators, like the GATA genes, with differential DNA methylation expression patterns have been identified in endometriosis. And just up the top here, I've shown you normal healthy endometrium. All these little lollipops on the DNA here, when they're white, they're hypomethylated. So the DNA is open and transcription can occur. And the genes that are transcribed are involved in decidualization and endometrial maintenance. GATA6 is switched off. There's no gene expression because it's got all little black lollipops because it's hypermethylated. This is normal. Now, in endometriosis, you'll notice that the GATA2 is hypermethylated and there's not gene transcription. So the decidual response is going to be abnormal, okay? And for the GATA6, it's hypomethylated, and so transcription is going to occur. And in this one here, you can see genes that are involved in progesterone resistance, altered estrogen responses like the estrogen receptors, but they're the other way around to normal, and steroid metabolism. So you can see how some of the things that you see in the clinic are a result of epigenetic changes in the stromal cells. Okay, and then microRNAs are the last type of epigenetic or control of the DNA and production. Really, it's either at the DNA, mRNA level down to protein. So microRNAs are small sequences of RNA. They're just up here. They bind to mRNA and they block translation. So they alter gene expression. They can be transported in exosomes and around to distant cells. There are also some long non-coding RNAs, and these are base pair with DNA and RNA, and one of them, for example, called H19, it's involved in ovarian and endometrial specific, and it modulates estrogen, progesterone, and androgen receptor responses. So you can sort of see how they could have a role. So these are involved in gene transcription and post-transcriptional regulation of multiple targets. They target many genes, each microRNA, and they alter gene expression. So it's kind of like the sum of all of that. So this review by Louise Hull shows the kind of processes that are affected by differentially regulated microRNAs in endometriosis under the kind of headings that we're familiar with in endometriosis: hypoxic injury, remodeling and angiogenesis, survival and proliferation. And here are the long non-coding areas, and they can circulate, and they're also in ectopic lesions. So the microRNAs and the long non-coding RNAs in endometriosis are key regulators in these other areas like the hypoxic injury, inflammation, steroidogenesis, and cell proliferation. So to summarise, what I've hoped I've been able to show you that there are some new concepts in the etiology of endometriosis that are all coming together with this retrograde menstruation. We've got new methods to study rare epithelial progenitor cells and endometrial mesenchymal stem cells. The sequencing technologies have increased our understanding of the hereditary and the environmental, which are the epigenetic contributions to endometriosis. The genome-wide association studies have found 27 endometriosis risk variants, and they'll be finding more, I'm sure. What we're trying to do is study them now in the endometrial stem progenitor cells and try and understand what they really do, because this will give us much more of a role of both in endometriosis. There really is now a two-cell hypothesis of endometriosis development. Somatic mutations and variants of DNA alter the utopic endometrial epithelial cells, and the epigenetic modifiers alter the utopic stromal cells, and I think the EMSC possibly too, that differentiate into decidualized cells, and when that doesn't work properly, that leads to the infertility aspect of endometriosis. So shedding utopic endometrial stem progenitor cells with altered DNA and gene regulation may confer ability to initiate endometriosis lesions in susceptible women, thereby refining Sampson's theory, I think bringing it up into the 21st century of retrograde menstruation. So I'll finish there. I haven't shown you my slide on endometrial organoids. I'm happy to talk about that afterwards if someone wants to ask a question on that. But in the interest of time, I felt I had to leave it out. But I also need to acknowledge all the people who've done some of the work I've shown you in bold here from my group, both past and present, my clinical and international collaborators, and also the funding bodies. And I thank you for your time and attention. Now,
Thank you very much, Caroline. And that was wow, because the inside story of endometriosis being so very complex with everything that you took us through. So there's not going to be a simple, straightforward answer very soon.
No.
The endometriosis will happen, and we will have many, many more cases to deal with. And
Yes.
what we are embarking on in the next section of the Knowledge Cafe. So who has joined us for coffee today? It's James and Daniel from Nairobi, Mayflower from Cebu City, Sharon by Samuel from Nigeria, Eleanor from Davao City, Leonard from Nanayuki, and everywhere around the world, they are now focusing attention to how the experts in India would manage cases of endometriosis. So we have with us a very distinguished panel. Dr. Alka Kriplani and Dr. Prakash Trivedi are very senior stalwarts in the field of OBGYN, a real asset to our country. They have held the topmost presidential posts of many, many organizations within and outside of the country. That would summarize their stature. And more importantly, they have extreme expertise, which they pass it on to the generation next. That is what I would like to highlight, the legacy that they leave behind with many, many students that they have trained in endoscopic surgery and fertility issues speaks volume of the fact that needs to be disseminated. The two other guests are my very beloved friends and colleagues from the city of Bengaluru, Dr. Madhuri Patil and Dr. Vidya Bhatt. Also, in the field of endoscopy and infertility, they have carved a niche for themselves, and the low resource settings and middle income countries like India, Asia, and Africa need to look at the same problems a little bit more differently, little smartly, in a little cost effective way. So give me a moment to just share the slides. And we have heard so much from Caroline that there are not going to be very many easy answers. So there is a lot of brainstorming for us to do over a cup of coffee at the Knowledge Cafe. And the aim of the treatment, as once again I will underscore and underline, it should be something doable, simple, successful, and safe. So the first case, as we had already elaborated in our promotional videos, is going to be on adolescent. Age no bar, because Caroline has already said right from the neonatal period, some cells will go here and there and everywhere. So this young girl presenting with severe dysmenorrhea, which is not an uncommon problem at all. More than 70% of our girls have very severe dysmenorrhea. So far, she has managed with pain relief medications. She is sexually active, and one such occasion where the painkillers did not subside the pain, she landed up at the clinic of any one of these four. And how would they proceed to tackle when they find large bilateral endometriotic cysts in this young adolescent girls? So the first question goes to the youngest in the panel, Dr. Vidya Bhatt. Would you do ultrasound? And I guess your answer should be
Yes.
yes. Yes. All the panelists can unmute now. Yeah. And then the next question is, the new generation OBGYNs typically are blamed for doing many unnecessary tests. She's only 18 years old. Would you do her AMH, free T4, TSH, TPO, Vidya?
See, if I am taking her up for surgery, she's just 18 years old. I would like to do AMH because now it is an era where we are talking about ovarian tissue cryopreservation also. So I would like to do her AMH. But more than that, I would want to do an MRI because, yes, I know that she has endometriosis by ultrasound and there are bilateral cysts. But the extent, the adenomyosis, the extent, and even rectosigmoid, because her endometriosis is quite severe here. She is having dysmenorrhea. So I would also want to rule out the rectosigmoid nodule and the rectovaginal endometriosis. So an MRI would give me a better picture. And then, of course, as a routine test, I would go ahead with the thyroid test. And then, of course, before I take her up for surgery, look at the ovaries. And then maybe a lot of counseling is required because these patients, it is just not surgery and end of it. We have to put them on medical therapy. And even when we are doing surgery, it has to be under a proper expert surgeon. Because if the bowel and the nodule is there, then a proper clearing has to be done. And it has to be a proper clearing for this patient, not just a half-hearted cystectomy and then there is a recurrence.
Okay, one rapid fire for my other three panelists. Vidya said MRI to really dig into where it is extending and what all is happening. Madhuri, yes or no for MRI?
No, I think today ultrasound has improved so much. So when we do a 3D ultrasound along with a 2D ultrasound, and if you really examine, I think it gives you quite a bit of, all the information.
Yeah. Prakash?
MRI?
No need of MRI.
Alka-ji? Dr. Alka Krupani may have gone for the other webinar, or is she still there?
Unmute Alka.
Madam, you need to unmute.
Unmute Alka-ji.
So I won't say blanket yes or no. What happens if you are good in your own ultrasound or you trust an ultrasonography person? Then only, otherwise what happens, we get reports which do not carry much meaning. So if you have any doubt, because MRI films we can study on our own and we have learned so much to. In this case, if you really, she has some rectal dyschezia or those kind of symptoms, then MRI really helps you in knowing how much is that involvement, and ultrasound, because it is investigator based. So if it is a good, reliable, it is a good idea, and she is unmarried. So in all probability, if TVS is not done in that issue, then MRI scores over, because you are very definite and you can study your own films.
Okay, yes and no, both answers, because it makes sense to
Emma,
investigations.
can I add a small point? See, first of all, I think so. All of us have 5 sonography machine in our clinic, and it is not by accident. Pelvic ultrasound and gynec ultrasound has progressed more by gynecologists than even radiologists, because I have taught at least half a dozen radiologists how to do a TVS. So basically, our fundamental point is you have to have a sonography, you have to have a color Doppler, you have to have your first evaluation. Doing MRI is, as she's pointing out, it is correct in the broader sense of term. But primary thing has to be a good ultrasound and a color Doppler. And if you're overworked, then you send it to a good radiologist.
Prakash, it depends in what setup you are working. At institute, we had 7 machines. It happens in big corporates. Sometimes many places they don't allow, and the radiologists are not good gynec ultrasounds. That I have seen.
I agree with you, ma'am, because most of the time the rectosigmoid and the rectovaginal is missed. And if we ourselves do a transvaginal scan, that can be identified. There's a paper on that in 2016 which gives the invasion of the rectal mucosa. We can if we are trained in that, we can identify. But if one is not trained in that, then we are leaving that adolescent girl like that to go through, and that will progress even to a bigger nodule. So it is better we identify it.
Okay, fair enough. I just want to ask Caroline, there is an issue about markers. Are there any markers that you would suggest? Are there already some evolving markers which would help us aid our decisions moving forward? Kindly unmute, Caroline.
I have to confess, I'm not a gynecologist, so I can't help so much on the really clinical side of things. I enjoyed the discussion that you've had and the various points that you raised, and I think that the real importance from the gynecologists I work with that to identify all the disease for the first surgery and remove it all, and I think that's a really important point. So that's all I think I can add.
Yeah, thank you, Caroline.
Caroline, we wish and pray that you do more research and bring markers. We are really in bad need of it.
Yes, that's why the question.
That is part of what we want to try and do eventually, but we've still got a bit of a way to go. We have to work out the cause.
Yes. So I think, the reason why I prompted that question to Caroline is there already something in the pipeline because research has to translate into management decisions that it would lead us to in clinical practice, and every additional information that we get, which will steer ahead more accurately as to what we need to do with the patient. So the findings that are put here, 3.5 into 3.1, 3 into 3, 2 large cysts on the right ovary, 5 into 3 into 4.4. So the left ovary is also both sides, it's showing a problem. Okay, so whilst everybody said that they will assess and reanalyze for the surgery, at this first visit, can any one of the panelists say whether you would like to defer the surgery or you would like to really?
Hema, I will just come here. Number one, we have 64% of the endometriosis which are picked before 29 years.
Yeah.
And to be very honest, they are mismanaged by gynecologists also. So jumping on the surgery is out of question. The volume which we are talking in the world is around 176 million people having endometriosis. And India alone is having 17.6 million. So basically, I think so. First of all, whenever a young patient comes, you just imagine it's your daughter, and then you put a knife in your pocket or a scope in your pocket. So basically, I think so you have to start understanding that her complaint is mostly endometriosis, pain. So I will not think of surgery. I will essentially not rush for a MRI because you can easily do a PR. And that is one. And then think of giving either progesterone or Dynogest or some other thing along with something which will improve her pain factor, and counsel her that if you do one surgery, it is no guarantee that in 3 years it is not going to come back. And
no, Dr. Prakash Trivedi is telling about per rectal examination. I want to ask both Alka and Vidya, do you particularly probe a history of sexual activity in many of our young girls in the present era, and you have the liberty to do a per-vaginal examination as well? Alka?
I live in the city of Gurgaon, and here I have seen the hymen has no importance, and majority of girls are sexual active. But from medico-legal point of view, I also do a PR, because for PV, if they are escorted by their mother or somebody, that family issue and they are not comfortable with. So we have to be very tricky in taking the consent and examining and writing about these issues, because otherwise we are supposed to take consent, and why go in all that?
Hima, you didn't
So
get
I
me.
would like to give one statement in an adolescent young girl who comes with an ovarian cyst. Don't take it that it is 100% it is endometriosis. Many times you will see there is hemorrhage in the endometrium, especially if her platelets were low for some time. So don't rush for surgery. Wait on for some time. There is no urgency for surgery. And now the whole concept is going on that defer till she wants to become pregnant. Like first love, first surgery gives best results for fertility outcome. So we have to change our mindset. Unless she is very symptomatic, keep her under close follow-up, give suppressive therapies, because if you repeat ultrasound in 6 weeks time, 8 weeks time, if it is increasing or decreasing, nature will take its course. Believe me, so many times you will see these corpus luteum hemorrhages which are increasing. And remember, young girls doing surgery, she will end up again and again in surgery, reducing her ovarian reserve, hampering her fertility. It is first surgery is best around when she wants to conceive if she needs it.
Okay, Vidya, I'm coming to Prakash.
You didn't get me. What I told is radiologists have a unique disadvantage. They don't do PV. That's why when you do sonography, when a ovum pick up, the needle comes from the sky as a vagina is pointing toward the sky. So basically what I was trying to tell is, we are from Bombay, you are from Bangalore, Caroline is from Australia, Delhi. There is no debate about integrity, about hymen. That we are not worried at all. Number one, I was telling PR for patient, you are worried about rectal dysplasia, complaint or anything, then good PR gives you a fair amount of idea. Obviously, I think so. If we actually see, 70% will allow you to do a TVS also. But that TVS, you are not going to actually inform to the relatives and all. But I was not worried about the hymen part at all. The rectum examination is only to rule out a rectal disease which is purely imaginary. Just she is having endometriosis, no complaint, and don't rush on the patient. Counsel her and take her slowly and then treat her over a period of time.
Yeah, so fair enough.
Prakash, I'm totally agreeing with you. We also do PR. PR is a very good examination. It gives you so much of idea whether pelvis there is fixity or mobility, and you judge operability. So PR is a very good examination.
I think the takeaways are that you get so much more closer to your comprehensive assessment by the history and the clinical examination, the PV, PR inclusive, the scans, the transvaginal, and if you want to plan something particular, then MRI also you're adding on. So you have all the data on your table. You will do the AMH perhaps as how it was voiced out that, for future fertility, you may need to take some decisions. Looks like Vidya has plunged into surgery. So Madhuri, can you tell her what the findings were on the surgery? Can you play?
Actually, this patient, she was on painkillers for 4 years, and basically didn't have relief. And when we did the surgery, she came with severe excruciating pain, which was not relieved even by injectables. And therefore, we were forced to do a surgery. And when we did the surgery, we found that there were bilateral endometriomas, which were fixed and adherent to the tubes and to the posterior wall of the uterus and pouch of the Douglas. And therefore, probably we did a surgery. And you can see over here that both the ovaries are adherent, they are fixed. And what we did was, because we wanted to, we wanted to take care of our ovarian reserve. So what we did was we just punctured and we removed the cyst wall. And we avoided cauterization as much as possible, because basically when we cauterize, we're cauterizing the cortex of the ovary, and therefore that's going to decrease the ovarian reserve. So that's what we did for this patient.
Okay, I would go back to Prakash and Alka. Madhuri said this was very stubborn, painkillers didn't relieve. Are there not any other medication that you would have tried on her before going in with the laparoscope? Prakash?
That's what I was trying to tell. First of all, you have to counsel the patient. Number one, endometriosis is a common condition. Pain, dysmenorrhea. If there is no dyschezia, don't worry about the rectal imaginations. And if there is a cyst, you have there are newer drugs which are available, which you take continuously for 2 to 3 months, along with something to relieve the pain. And you tell them this will make you better. See, the moment if it's an 18, 19-year-old girl, you immediately tell her for surgery, they just run away from your state to another state.
So they go to Alka. What would Alka say?
I'm very clear. Any drug which leads to amenorrhea will, in all probability, subside her symptoms. Having published trials with majority of all these drugs, I have found that this new oral contraceptive for young girls, which contains Dinogas, you see the same amount of Dinogas, 2 milligram. The companies are making it, and 3 days is easily available. And 30 microgram of ethinyl estradiol is a very good drug. And literature says that you give continuous, but I have seen breakthrough bleeding, so it comes to same whether you give cyclical or continuous. So for prevention of recurrence, since you are operated like this, it is very important to put the girl on a suppressive therapy. A younger girl, a combination of Dinogas with estrogen, which comes out to be cheaper than Dinogas, with the same amount of Dinogas, is a very good idea.
Yeah, this girl, basically we had given her 6 months of Dynogest, but she has not responded to it, and the pain was so.
Yeah, fair enough.
That's it.
We are not debating that you are doing laparoscopy and you are not doing cystectomy and you are just draining the cyst, chances of recurrence in the next 6 months are 67%. That is the reason,
No, we have done a cystectomy. The next video is showing that we have removed the cyst.
Okay, Vidya, would you have gone in with the laparoscope and done something differently, or will it be the similar procedure?
Can I show a video, ma'am?
Yeah.
Yeah, because
is this yours, Vidya?
No, this is my one where we've done the cystectomy for the patient.
So Alka ji, you're happy?
Please don't feel offended. Majority of people who send the patients to us, they just do cystectomy, and for that matter, Vidya, me and Prakash have to, undertake more training courses and teach people how to do a proper cystectomy.
Yeah.
So we have done a cystectomy for the patient.
To add this, I agree with all of you that first instance you should not go ahead with the surgery. Of course, depending upon the cyst size, we try medical therapy. We also try giving Dynogest. But in this particular case, which I am showing you in this video, it is a huge cyst. Actually, I thought it was a fibroid, but the whole
Vidya, Dr. Vidya, do I have to move out of the slide?
No, you just stop sharing.
So yeah, I will stop sharing so Vidya can start sharing her slide.
So
have you?
Young girl, she came to me with a huge cyst. Initially, we thought it was a fibroid, but it was a big cyst. And the ovaries really looked a little abnormal. I was worried what's wrong with the ovary. We could retain the ovary. Of course, here I had to use energy. This was the whole abdomen. Young girl, she was just 16 years. and she came with severe anemia and pain. So in such cases, there is no question of trying medical therapy. But when we did this surgery, post-operatively, she was perfectly all right. Of course, look at the cysts in this ovary. I thought it was something abnormal, but later I realized that it was the ovulation which was occurring, and this smooth cyst was giving that kind of picture, and it was the mass like this which looked initially, and this is the post-operative abdomen, and this is the amount of fluid which was there, and this is the cyst. Now later we followed up with medical therapy, and now she almost
Such a big session.
Yeah, Vidya, but there is Madhu Sharda from Jaunpur. She is asking, should we do the markers to rule out carcinoma in such cases?
CA125 and all this, yeah, you can do it. But here we had got an MRI done, and though none of the markers are very specific, so I think MRI really helps to know the type of the cyst, the number of cysts, and to what extent. So we did an MRI and we did the surgery.
The marker should be done only for a follow-up. So basically, when it's not diagnostic, but
Vidya, can you stop sharing the slides? Yes, thank you. Prakash, in the true keeping of the Knowledge Cafe, is happily sipping some coffee. Yes, Prakash is having his coffee at the Knowledge Cafe. Good. Prakash.
You should be happy it is coffee only, Prakash is taking.
No, coffee and chocolate, there are two things. Chocolate
is coffee. Mr. Julius from Kenya says it's a very informative and resourceful session. So get going, panel. So we are thriving on the agreeing to disagree factor. So one rapid fire for everybody. Madhu's question. CA125 in an 18-year-old with this before doing anything else. Will it add value or it's just a wasteful another place?
CA125 is non-specific. It rises in tuberculosis, it rises in pregnancy, it rises in peritoneal irritation, it rises in endometriosis. It is just an... but as Alka pointed out, I will agree with her. Suppose if you have done an endometrioma and somebody had done previous CA125 and there is recurrence or not, little bit value it will have when you're talking about some recurrence, but otherwise CA125 or any other marker has no role.
Yeah, so Madhuri and Alkaji will agree with that?
Yes. I get particularly CA125. A number of times it has happened with me, it was in hundreds. And one was a medical student from Lady Harding, and then it came out to be, in her case, epithelial cancer and hemorrhage in it. So now we are in the era of medical legal, and it shows you the active infection, and it helps you in follow-up.
Can I share?
And to pull out medical legal, if it is in about 200, 250 or so, and her case was 400, so I said I won't do laparoscopy, and it came out to be cancer. So it will happen once in a while. But it is really, medical legal saving.
Yes. Hima, can I?
Yeah. Prakash?
Yeah, Hima, it's good and incidental. We had a patient from Delhi, unmarried, with CA125 of 568. And when she entered, consulting, the family entered in say as if she's going to die in 1 month. And then we saw there were 6 pockets of cyst, and there's a hemorrhagic corpus luteum, 30 to 40% of this. So first of all, we counsel that you don't worry about the CA125. We did a color Doppler. We went ahead, we peeled the cyst, and later on when she got married, I remember I told Nalini Mahajan in Delhi to take care. She conceived and everything was fine. So what Alka is telling is correct, but you may get a very high CA125 in tuberculosis. So unless and until your color Doppler or something else, in MRI is strongly suggestive. Don't worry too much about CA125.
I agree with you. If the CA125 is really high, then you should suspect endometrioid carcinoma. Even I have had a case which has come like that, and I have opened the case.
Prakash, we are in such high medico-legal times, even one case. So, it's a good idea to follow up also. So, and I had cases. So, usually nothing happens. 250, 300, CA125 histopath comes, endometriosis. That I agree.
I would want to place one thing. There are so many unnecessary tests anyway, which the patient nowadays undergoes. So doing one CA125, which may add, even in an anecdotal case, once in a blue moon, if it adds some value and it changes your thinking about the case, then I think it is fair enough that keep this thought in mind and maybe test, knowing fully well it's non-specific, but if it's unusually high, it will start, it will compel you to rethink the process and see what better you should do in a particular case. Yeah, but that is.
Here's the question which was asked. The person is clearly asking whether C125 has importance or not. So you may do C125. You have a level. You do a Doppler and MRI, which will suggest if there is something. So take home point is you may do CA125, but don't put tremendous importance unless until MRI and Doppler is showing you something.
Yeah. So if you do, you please correlate with the other things that you have done. And there's one Davos City where she asks, is there any specific measure where you will remove the endometriotic cyst? At what size you would consider removal of the endometriotic cyst?
Whom you're asking?
Madhuri, you said endometriotic cyst was removed.
No, the wall was removed, not this. I mean, the same. So the cyst wall was removed, so that the recurrence rate is less. But I have also seen many patients who have come to me now for infertility, wherein they've undergone oophorectomies, and I think that should not be done. So if you're suspecting malignancy or something, it's best to do a frozen. You do a surgery where the frozen section is available. You do a frozen section, and then
don't take decision on these young girls' gonads on the basis of frozen. Number of time report changes. And you are very right. That is the reason for years I'm teaching surgeon friends. These girls call surgeons. They don't respect ovaries. They don't know how to do a good cystectomy. They do oophorectomy, and this is the usual story.
And I think oophorectomy should not be done.
I don't remove any normal looking ovary even at 55.
Yeah, so you may plunge it.
There is no question about, but see, there is not, it is not only the size, Emma, it is the pain, other parameter, infertility issue, associated issue, which will be deciding factor when you operate or not, because you want to operate only once, so that after that she gets what result she wants, so that there is no recurrence.
Yeah, can everybody, if you're not speaking, just kindly mute their system, because there's a lot of Caroline, Chandana Murthy. Yes, thank you. Prakash, go ahead.
No, what I was trying to tell is it is not necessarily 5 centimeter, 6 centimeter or something. Sometimes you may have a very large cyst like the one which Vidya showed, and when you go inside, you find it's a para-ovarian cyst and the ovary is totally normal. So basically, when you're talking about an endometriotic cyst to be operated, parameters are, one is size, second is symptomatology, pain, associated infertility, and if you're going to do surgery, you are mentally doing in such a frame that you are the best surgeon, you're going to do the best surgery, and will make provisions so that she doesn't get recurrence fast. If she's keen for fertility, she gets pregnant fast, so that the disease runs away. Otherwise, there will be too many repeated surgeries.
Okay, the panelists at one point in time opined that no, let's not hurry up with the surgery. Let's try out other options. So Prema Dekuna from Mangalore asks whether if you delay the surgery in the cases of endometriosis, would you be giving time to enhance the tubal damage and other little problems that it can create at this point in time, which will have far-reaching consequences? Alka?
Actually, that is true, because if a cyst is gradually or fast increasing in size, It may compress and damage the normal ovarian tissue. Tube, I am not sure, because tubes are usually spared in pure endometriosis. So that is the reason endometriosis is called an enigma. Today, before coming to this webinar, 2020, very nice article I was reviewing, and you know what was the conclusion? More RCTs should be conducted, because it has to be highly individualized management with lot of experience. You cannot make blanket that operate 4 centimeter and above, not operate below. If you are doing a good ultrasound or MRI, you will see there are different type of endometriosis. In some, normal ovarian tissue is not seen anywhere. In some, it is big cyst, but it is at the periphery. And good amount of ovarian tissue is there. So there are a lot of things. I think from practical point of view, you should be very patient in that surgery. Nowadays, we use pitresin in correct layer, and you have to be very, very conservative in your approach, thinking what will happen to her AMH later.
Hema, one point, since Caroline is here, and of course everybody else is there, when you have endometriosis, the tubes are patent. Endometriosis occurs 64% before 29. So when they additionally have infection, that means they have gathered the infection afterwards when they are sexually active. If you see pathologically, more macrophage, less endometriosis. So if you have infection, there is less endometriosis. So if you have more deliveries, more PIDs, you have less. So usually the chronology is endometriosis, little late marriage, tubes open, then they catch on. So basically tubal function is not affected only because of endometriosis, but then associated inflammation and infection can make the tubal function partially affect, but otherwise it should not do anything if they are taking protection and using other medicines properly.
So Caroline, add something?
Just 1 second, Alka.
Very good point. Because number of articles in the literature are there showing that first there is infection, and 2 infections are seriously implicated, schistosomiasis and tuberculosis. These inflammatory reactions change the milieu in the peritoneum, and she lands up. So whether it is effect or cause, and there are studies showing that it is the cause. First there is infection, then endometriosis, and majority of time endosalpingeal damage is not there unless there is associated salpingitis systemica nodosa.
Yes, so Caroline, is it good to have infection or is it not good to have infection? What does infection do? It
Well, doesn't it
causes or it restrains?
I've got to unmute. Where am I?
Yeah, you're unmuted. We can hear you.
All right. Okay. Well, I mean, I think one thing I could think of is that infection does lead to scarring too, doesn't it? And fibrosis.
Yep.
And can't that, especially in the tubes, cause a bit of problem as well, eventually when she wants to get pregnant? I don't know. I'm not the clinician. I don't have the experience that you people have.
So Madhuri, what is your take on Alkaji says because of the infection, endometriosis blows up, and Prakash Trivedi feels that if infection is there, then it prevents a retrograde spell, and so maybe things get better.
What happens is, if it's not the endometrioma, but it's a peritoneal endometriosis, and then the endometrioma occurs. So this peritoneal endometriosis, normally there is an inflammatory reaction, and therefore that can also affect the tubes. If it's just a pure endometrioma, probably it will not. But usually we see that these endometriomas are associated with peritoneal endometriosis, and when you have peritoneal endometriosis, there is inflammation. And when there is severe endometriosis, like this patient had both her tubes, totally very unhealthy, and they were not, they were totally edematous. So probably there was some amount of tubal inflammation in this patient.
Question to Dr. Alka Kruplani from Dr. Adopatu from Nigeria. Was there any measures put in place to prevent intra-abdominal adhesions in the patients whom you operated?
I tell you, the best adhesion prevention is operating in the correct plane and not leaving blood and not using too much of cautery. Rest companies keep pestering us, put Interstate, put this but I am not convinced that there is clear evidence that any other adhesion barrier is a good idea, except your correct operative technique and nice wash at the end.
Yep. So
Prakash should deliberate. He is a very high volume surgeon too.
I know there are many people
Totally
who are quoting Prakash's surgery done 7 years back for my patients. Thank you very much. So Prakash, you're getting thank you notes also from your colleagues who have referred the cases to you.
No, I agree with Alka what she's telling. Doing a good surgery, see, we have laparoscopic myomectomy, endometriosis. Endometriosis is more of fibrosis. Caroline may be aware at this moment, like Australia, India has probably greatest laparoscopic surgeon for endometriosis and fibroid. In fact, I had gone to Australia for a lot of education in endometriosis. So basically, I think so you do a good surgery, clean surgery, and leave least damage. Don't trust any company because somebody says this prevents adhesion, the other person finds that it leads to adhesion. So good clean surgery is the best answer.
Yeah, and Madhuri, GnRH agonist depot preparation, would you have liked to give?
She's an adolescent. She's just 17 years. I would avoid giving an agonist preparation because that's her growing period. So I would prefer giving her Dynogest or an oral contraceptive.
Emma, can I make one line statement here?
Yes, please.
GnRH agonist is a relative contraindication in young girls. There are a number of studies in the literature showing it is directly proportional to BMD loss. These are bone forming years. Your bones are formed till 30 and then they get absorbed. So in these young girls, giving GnRH has led to long-term BMD deficiency, and you should not give them GnRH. All our literature.
Now, since Dr. Vidya Bhatt has done the MRI and found out something near the rectovaginal region, what would you do in this case if there was a rectovaginal endometriosis, Vidya?
Ma'am, that has to be excised. If at all there is rectovaginal endometriosis, we see first thing is a proper clearing. That is, a cystectomy is done, then the lesions are looked for and the lesions are excised. And if there is a rectovaginal endometriosis, a clearing has to be done. And as Alka Madam and Prakash sir rightly said, it is a good surgery. There can be adhesion. Post-operatively, we should put them on medical therapy, but on table, there should not be any hematoma formation. There should not be any bleeding left. It has to be a clean field. Only then we'll have a good outcome of the surgery.
Whenever there is a possibility, I will show the video about the advanced endometriosis. You can continue with the question. The question what you're asking, there is an absolutely perfect small video for that.
Yeah, so please. I will stop slide share so you can go ahead with that. Meanwhile, presacral neurectomy. Somebody says with endometriosis, she has the pain going all over to her legs. So can this be a cause? So would it help if you do a presacral neurectomy? Alka, go ahead and answer. Meanwhile,
We are years back, we used to do presacral neurectomy, even open. But now concepts have changed. These nerves are very important for bowel and bladder function. Luna, the procedure with the at uterosacral, has totally fallen into disrepute because it is very temporary, if at all it is effective. Presacral neurectomy, if you are damaging the nerves there, these nerves are very important for lubrication, sexual function, and especially constipation and things. So I don't think, even Prakash, we are nowadays not doing presacral neurectomy.
Yeah, I will just add one point. 1997, Kamran Izzat came.
Yeah, I was there.
First time I saw a presacral neurectomy, and after that, in so many years, I have done 56 or 58 presacral neurectomy for endometriosis and more for severe dysmenorrhea. And very surprisingly, lots of these patients were ready to do even a hysterectomy. And as predicted that you can have bladder dysfunction, etc., many of these patients had painless delivery. So basically, I think so we have to understand that it's not all that bad procedure, but in today's time, I will agree with you that nobody will go for a presacral neurectomy. I'll quickly...
Nowadays, Even in severe endometriosis, we try to preserve nerves, try as much as possible to preserve.
That is because people have got neurosensitive pelvic neurology and all. Hema, if you focus,
yeah, please, Prakash, can you explain what you're doing?
See, now both are advanced endometriosis, and the important point is that you actually restore the initial anatomy. Most important structure is the ureter. So once you separate the posterior, that is the ureter there in the right frame. So your basic point is you go from a normal tissue towards the diseased tissue. So that's point number one. On the left one, you are seeing that the ovary is being separated, so that the ovary is separated from the surrounding structure. There will be endometrioma. You identify the ureter nicely because ureter is very typical, because when you have chocolate cyst structures, Alka will agree that it spoils the plane. So in the left one, it is with the rectal disease with Vidya was mentioning. So you will first separate the ovary nicely, and then you reach to the rectal area. On the right side, if you are seeing the ureter, these are all actually endometriosis, which is getting split nicely. And on the left side, you can see the rectal area is cut more close to the uterus. So what happens is there are two principles. Either you shave it, or we very recently, Sailesh Vote as my place, we did a large bowel excision. But basically you have to remember, you can shave a lot of lesion. Most important is to maintain integrity of the rectum, go into the right plane. For that, you are actually leaving disease on the rectum. So you are going more towards the uterus, and then that can be held with the tenaculum, and then you can grip the tissue. As Alka was rightly pointing out, advanced laparoscopic endometriosis is surgery limited to few. So suppose if we have many laparoscopic surgeons, we have to admit that this is my limit till what I will do the surgery. So like somebody, I can do a radical surgery, but that doesn't mean I become a cancer surgeon. So I think so. The point what is clear over here is, see, everything is freed there. So that should be the end of the surgery. I'll stop.
Prakash, I really appreciate you for this statement. Nowadays, everybody is after rectovaginal endometriosis. One, if the patients are symptomatic, then only. And somehow in our patient population, ovarian endometrioma is much more common than deep infiltrating endometriosis. Thirdly, you should know your limit and should not be unnecessarily invasive.
Yeah, now this I will not show Emma, because this is only just to tell an infertile patient having bladder endometriosis and ureteric endometriosis. I will not show this video so that questions are not cut. But this is a patient of 34 years, both keen to conceive, and we did a bladder excision and ureteric anastomosis. But I'll stop here because I don't think so anybody is interested to go into surgical expertise.
No, they must have enjoyed your lovely video.
Yes, very nice, very nice. Alka ji, again, I want you to repeat the issue about combined oral contraceptive tablets having the Dynogest. You mentioned that it will serve good in these cases. So somebody is asking why to give unnecessarily the estrogen component in a combined pill. Will the Dynogest?
Very good question. Very good question. You see, whenever you give GnRH or even Dynogest, any progesterone, if you give alone, there is high incidence of breakthrough bleeding. If you give GnRH, there is hypogonadism. So little amount of estrogen is a very good idea. Previously, we were using OCPs a lot, but now young girls, OCP with little estrogen is a good idea. Perimenopausal and late endometriosis, only Dynogest. Very fond of Dynogest because we have number of cases and studies.
Yeah, the question to Madhuri is from Shweta Singh, Greater Noida. How prone are these cysts for torsion, and above what size the torsion is likely, if at all? Madhuri?
So basically, if they are free, then only there will be a torsion once they increase in size because of the weight. But many times what we see that these cysts are adherent, and usually the chance of them undergoing torsion is very less. So unless they are free floating, I mean, if they're too huge, then with the weight, they undergo torsion.
Yeah. So Priya Mahesh from Mysuru asked Vidya, but do you use Interseed during surgery? What's your opinion on using it?
I think just now there is a lot of discussion which has gone around saying that the best addition barrier. No, sometimes I have used, it's not that I have not used Interseed, I have used Interseed. But one thing is it works out very expensive to the patient because now it is around 6,000. And second thing is, suppose there is a hematoma or if there is a bleeding there, it is a nidus for infection, and sometimes they could develop abscess and all these problems. So that's why you have to use it with caution, and only in cases where you really want an addition barrier, you feel okay, it is adherent to the bowel, so maybe I have shaved it out. There you can put it, but still it is not the best one.
Hima, Vidya and Alka, one small point. 1997, Kamran Nezat was very much fond of Interseed. And Anthony Luciano, who came along with that was one first big great conference we had. And Anthony Luciano showed that using Interseed increased adhesion. So you have to understand that we use something in presumption that it is going to be useful. But there are less studies which are done to see it again, whether it actually prevented. And we have so many patients wherein we have operated, they are pregnant, cesareans are done, or somebody has done cesarean, or some repeat scope is done, and you find everything is nice and clear.
Yeah, definitely. The perception is that you use this and it will become better, but the literature and the evidence against it is contrary. Dr. Latika Agarwal from Bareilly and many of Alkaji's fans from that belt, somehow they're all asking again and again about the markers. So Latika's question goes as, it may be a hemorrhagic cyst, it may not be, and will markers not help in diagnosis? Somebody else again says, can we not do some markers to see what the way forward is, whether to do surgery or not? So there are about 6 questions. Everybody wants to know about anything with the markers. What are these markers and what do you suggest? Should we do? What is the
PA 125 is a marker of peritoneal irritation or involvement. It has nothing to do with cancer, I tell you. That's why in tuberculosis there is ascites, there is disease. You will find it in hundreds. But by and large, see, you say that we are unnecessarily or doing too much investigations. See, why was it All India Institute, so many cases coming up through MCI? You have to practice defensive medicine also. You have to see. And if the marker is very high, it alerts you whether there is something else, whether there is tuberculosis, whether there is associated cancer, it is a hemorrhage in the cancer which is looking like that, and you are your approach is guarded towards tackling it laparoscopically.
And Anshumala Rastogi comes back to the question on ethinyl estradiol and Dynogest. Should you give it cyclically or continuously?
Very good question. The evidence is that it is marginally better when it is given continuous. With vast experience, we have seen it comes to same. You give continuous, there will be incidences of breakthrough bleeding. So it comes to, and if you give cyclical, they have predicted periods. Indian women are very distinct period, can't go to temple, can't go to the husband and all that, can't touch kitchen. So these spotting, they're very much bothered, unscheduled. I give it cyclical with the simple reason they have periods predictable.
Will they also work? Will Dynogest also work in scar endometriosis?
I'm doing a lot of scar endometriosis nowadays.
This is Hansa Kushte from Amritsar. Yeah.
So, yes. Scar endometriosis, because of scarring, vascularity of the area is compromised. So any drug is logically not going to be effective. In practice, I have seen you start a drug, it acts for some time and gradually it stops working. Scar endometriosis is best treatment is surgical excision.
Prakash, there's a question on can we use novel saline instead of pitricin? This is from Malegaon, Dr. Shashikant. Wow.
For endometriosis surgery or what?
Yeah,
mostly I think so. The question, this is a very common question because in vaginal surgery, we put 2-3 drops of adrenaline and use saline. There is a vast difference between using diluted vasopressin And from 97, we are using right, left, and center vasopressin in a proper fashion with huge fibroids and multiple fibroid. Effect of vasopressin is far superior. There is one product available even more than vasopressin. So using normal saline and all is like just aqua dissection.
Yeah.
Whereas if you use very often, if you saw that endometriosis surgery, in fact, I have one video. Currently, we inject a little bit of dilute vasopressin, even in endometriosis and just the wall. So it gives you a nice plane and it starts separating. Then you drain, then you can remove it. So vasopressin use and saline use are totally two different things. Because saline will just disappear.
Absolutely.
Hema, vasopressin leads to avascular planes. But please remember, I have seen you have to put it in the correct place. Otherwise, wherever you deposit vasopressin, you may remove lot of normal ovarian tissue.
Yeah, there is one doctor.
So be very, very thin stripping of the cyst lining.
Yeah. So again, the more
Hema,
surgeries. Yes, please.
See, when you have advanced endometriosis, most funnily, vasopressin is injected in the superficial part of the uterus, which is a very surprise thing which people do. When you have a cyst, there is no debate. You can just inject, like with a small needle, just go into the plane and it makes things easy. I have a fantastic film on that. But again, as there are two things. Vasopressin in fibroid is a miraculous thing. Vasopressin in endometriosis makes surgery easy. But most important thing in endometriosis is to save ovarian tissue. So you don't want to go in a wrong plane and remove more tissue in the chakkar of vasopressin.
Agreed. So meanwhile, just allow me a second to share the slides again. Meanwhile, Nutan Yadav from Mumbai, I want her to again put her question in the chat box for the sake of completion, because the question is to Dr. Prakash Trivedi. She says, 36-year-old unmarried, operated for endometrioma, which was 5 centimeter. This was 7 years ago because the medical treatment failed. What will be the best treatment for her now? But Nutan, we want to know before Prakash answers, what is her problem now? Because she says 36-year-old, but her old case of operated endometrioma, and what is the best treatment, medical treatment for her now? Is that the question? So Nutan will take a couple of minutes to key in.
As Nutan is asking, Hema, I understand her question. And this is what Alka, me and everybody keeps telling. An honest confession of a laparoscopic surgeon, 80% of laparoscopic surgery done for endometriosis is incorrect. I also do sometimes incorrect endometriosis surgery. So basically what happens is, quite often somebody does a very inadequate surgery and that person has residual disease. It's not even recurrence. So basically you have to see who has done the surgery. If somebody who has done surgery is known, say for example, from Chennai you have a friend, from Calcutta you have a friend, Delhi you have a friend, Bangalore. So lots of people whom you know. That doesn't mean if you don't know it, that person may not be a good surgeon. But what I'm trying to give an idea is recurrence is 75% guaranteed in endometriosis. So you have to understand, first surgery is the best surgery. 36-year-old patient had previous surgery done in an average center, now comes with proper endometriosis, with a lot of pain, keen to conceive, etc. You will consider that as the first surgery. Okay. After doing the AMH, and do the best and see that she gets desired result, relief of pain, conception, and excision of disease.
Prakash, one quick question about dilution of vasopressin. This is Jayashree from Gadag. Can you just repeat?
Yeah, it is 20 units in 100 ml. See, there are different dilutions used. Now, this is a very good question. When we remove 15, 16 fibroid, so one dilution, 40 units is the maximum you are supposed to use. So 20 in 100 ml when you have used, you will finish 3-4 fibroids and you suture it back. Almost 45 minutes is gone. Then you can use another 20 units. You're not supposed to use more than 40 units. You're supposed to use 20 units. We have not had experience, but let me share a true incident which happened. I will not name the city. wherein an ambulatory surgeon in hurry injected so-called vasopressin, and the patient just went into arrest. And in accident, they realized that instead of vasopressin, adrenaline was given. So a good surgeon who is going into an ambulatory place, they injected, and this I clearly remember because I think so my son was there watching the surgery, and the surgeon is fantastic. So you have to remember to be very sure about the dilution. Your sister also, you have to be sure what they are giving, which has to be precise.
Yeah, so
I would like to add here, in spite of all precautions, accidents happen with Prakash may be very lucky time to time. And our anesthetists, they say that anesthesiologists have made guidelines and they are not allowing more than 5 in 100 or 205 units. So we have decreased our dilution because I also had a very severe reaction patient. All right. But we have to be really careful. And they say it is not only the amount of the drug or going in the vessel, it is some pharmacological compound carbon or something in it which leads to very severe reaction, 1 in million. But then you may be in that.
I always tell to my anesthetist when I'm injecting vasopressin, we have 2 pulse oximeter. So one NIBP which is observing the patient, and I tell Anthony, my OT assistant, to put pulse oximeter on the finger of the anesthetist. Because half of the time when you are giving vasopressin, their BP goes up and their pulse goes up. But fortunately we have not had, but there are enough. You also had one case we had discussed, somebody else had a case. So it's not that it is not going to happen. Somebody is going to happen.
We have to be very careful in using the dilution, and the beginners, I would say, should use less dilution.
Yes, ma'am. Agree with you.
Fair enough. Yeah, Vidya?
Yeah, 10 units and for 5 units, because anesthetists are very particular of the sudden reaction which
their guidelines have come. He was telling me that day that our anesthesia national guidelines have come because number of accidents have happened during myomectomies, so they are not allowing more than 5.
So Prakash, would you agree that 20 was the usual, but now 10 and 5 to be considered?
I will give you a very good example. See, at Narendra's place I was operating, many places I was operating. Now, one very important thing as a surgeon, a laparoscopic surgeon has a big ego. So whenever I start a surgery, I first mention what is the name of the anesthetist. And I mention that we all are living and we are good endoscopists because the patients of the anesthetist. The anesthetists have made us. Once you have made this statement, your 10 units to 20 units, they will smile and allow you to give. But when you are injecting, you have to tell the moment you have sense any problem, we'll stop. So I still use 20 units. There is no problem. See, one case I will change the concept. But we have few anesthetists. I remember in Cochin, Chennai, Bangalore, Bombay. They're not that much worried. But some anesthetists have seen 1 or 2 cases. They are very fearful, as Alka was rightly pointing out.
No, fair enough. I think we've got a range of inputs.
No, just 20 units in 100 ml or 20 units in 200 ml, and use only optimum as necessary. Don't use too much.
Yeah. So
the crux of the matter is that pitresin is maybe a very dangerous, potentially dangerous drug. Use with caution. Keep an eye on the pulse. Inform your anesthetist and use minimum amount.
Yes, excellent. So I think that's a good sabab. Madhuri, can you just quickly recap? We were talking about young girls with routine painkillers, not relieving them. Don't rush into surgery. Try something that could work better. So this is a slide that you have put up on the newer compounds. Can you just tell us a little more about that? And do you actually use it in your practice?
So this is a new compound which is not available in India now, though it's available outside. And the second generation GnRH antagonist. It's called as elagolix, and it can be given orally. And basically, it's given they have tried both the doses at 150 and 250 milligrams. And they found that both of them are effective. So it's better, and they've said that it's better to give a lower dose because again, it's an antagonist. It can also affect the bone mineral density. It can be given, normally it's given for about 3 months, and it's basically only to relieve pain. It does not reduce the endometriosis. And at the most, it can be given for another 12 weeks. That is for a total duration of 6 months, not more than that. And it's only for pain relief. That's all.
So when we're talking about the future of this young girl, somebody has already asked these relevant questions. How soon you can allow her to conceive? Suppose she was 28 and she'd come to you with this.
Once if you have done the surgery, the best fertile period is immediately after. See, if you see the term pseudo pregnancy and pseudo menopause, the treatment itself is named as pseudo, means it's not actual treatment. You are making the patient menopausal, or you are making the patient think that she's pregnant. Immediately after surgery, first 7 months is the best immunological period, wherein just one cycle, if at all they want, they should wait. Put her on active fertility treatment. Plenty of them will have, 23% will have spontaneous pregnancy. You start active treatment. Madhuri is sitting close to your place. Whatever you use, letrozole or FSH and IUI, or if there is a need, most important thing as a surgeon, open or laparoscopic, don't hold the patient for a long time. Good surgery with good ART facility really goes a long way, because many of these patients come at 37, 38 years old. And if you hold them for long, then you have to go for oocyte donor.
Yeah. So I think the viewers will get many more answers from the second case. But on the first, we would conclude that yes, take the patient into confidence, counsel her properly, give her the options, no matter the size, and the concept of the markers have also been very well cleared out about what, and even the elaborate investigations, how much and how little, and an option of the combined oral contraceptive pills vis-a-vis the Dynogest alone, as well as if it comes to it, then what kind of surgery you must do, the pluses and minuses of vasopressin and intercede, which are simple practical things for all of us to remember, and also the preservation, which is, the conservative mindset that you must have with caution during surgery. So these were some of the learning points, in addition to the fact that some have already asked about cryopreservation, which is one option, and using the best surgical technique, which everybody has emphasized again and again, and avoiding unnecessary surgeries. And in a nutshell, for everybody, the underlining thread is the role of lifestyle modification and, other issues where epigenetics plays a role, which Caroline adhered to. So you never know from where the help is coming to this patient of endometriosis. So we then come to the second case, which
before that, Hema, I want to say something.
Please.
It is such an excellent summarization that me and Prakash have also learned from you.
You have chosen the best moderator who doesn't know anything about this issue, so she can, pay attention and grasp everything.
Too good. And you have summarized this better than me or Prakash would have done.
Hema is a master in understanding people and explaining.
Master.
Thank you very much. This brings us to another challenging case, bilateral endometrioma, now with infertility, and she's had one laparotomy, 2 laparoscopic surgeries, she's gone to the ART centers, 2 failed fresh IVFs, 2 failed frozen embryo transfers, and she's 32 and 5 years have gone by, and she is really, as anyone would be, is really fed up. Even today, the endometriomas are persisting, and in addition to that, bilateral hydrosalpinx. She's not ready for clipping of hydrosalpinx because she's undergone multiple surgeries. Now, I stop here to say this issue about clipping of hydrosalpinx, to do or not to do. Prakash.
I think so. Any time when, especially this person who has undergone so much, it is very easy to convince her that your fluid from hydrosalpinx goes into the uterine cavity and it prevents pregnancy. So if you remove, this just accidentally reminds me of my friend lead Dr. Rakesh Sinha. We used to joke very often sitting in the porch of Nair that we can convince an infertile patient to remove tube and prolapse to do a laparoscopic surgery. But the fact of the matter is, clipping, there are 2 points. If you have a good endoscopic surgeon, then taking a permission for salpingectomy really improves. There are absolutely specific data. I have the figures also with me, which I will not tell. When you do salpingectomy, you don't do refill, etc., and all. But you have to convince the patient that we are not going to AMH, etc., because AFC is 15, AFC is 18 till a reasonable period of time. If AMH is not bad, you will tell her that I will do a salpingectomy if, for example, the person doing finds it difficult, clip and drain the fluid. Otherwise, the toxic fluid remains there, and take her up for an ART, and you'll be surprised that they may have a good result.
Alka ji, could you put
this? Say something, and
yeah, please.
For the benefit of everybody, these IVF people, our friends, they always say clipping, and the patient thinks that she will just put a clip. Doing it in large numbers over the years, I have realized we are good lab surgeons. Salpingectomy is always, looks a better idea to me, a proper, not, going too deep and destroying blood supply to the ovary. You can always do that. Salpingectomy, a good salpingectomy is always a better idea than this clipping, this sexy.
No, I mean, basically, there are.
What do you say, Prakash? I want to.
Alka, I think so. You are right, and ART people are also right. Because what happens, ART person is usually an ambulatory person who is junior, who comes.
Madhuri is listening.
Huh? No. I will tell. I used to regularly operate for Dr. Sarna Desai, then somebody else, then somebody else, then somebody else. So what I'm trying to give an idea is sometimes some person feels, because I don't believe in clipping at all. And I don't believe.
I thought, yes. So this clipping thing, either we teach them properly or they send them to us. Why do a half-hearted job?
See, second point is many times they clip a tube which is blocked, which is not even enlarged. So there is already a lymphatic disease. So where is the fluid? So if there is an hydrosalpinge, to do a salpingectomy, as you're mentioning, is very easily possible. Clipping, according to me, is a half-hearted job.
My opinion. Otherwise, people, they catch me by neck whenever I make this statement. For years, I'm realizing it is a bad idea.
Madhuri, one rapid fire question both for you and Vidya. Okay. Now that there is an opinion, no to clipping, better to remove the tubes. Two things. Would you agree with that? And would you have thought that somebody should have done it in her previous laparoscopy?
Yeah,
laparoscopies have happened, and they must have seen this hydrosalpinge tube. Whether they would have done something then, or do you think?
They should have done, but this patient, when she was operated for the first time, when she underwent a laparotomy, she had bilateral endometriotic cyst with an abscess formation, and they had done a laparotomy then. So post then she had developed again endometriosis, and she had a frozen pelvis. So when they did the laparoscopy for the next time, probably there was a frozen pelvis and therefore they didn't do anything. And the hydrosalpinge was diagnosed basically on ultrasound. So even when she came to me, I said that if it's a frozen, even if there's no adhesions, I would also like to do a salpingectomy. But in this patient, because it was a frozen pelvis, I prefer doing a disconnection. I don't put a clip also. I just cauterize the cornual end with the bipolar and I disconnect the tube. So,
I would do
a salpingectomy, ma'am, because large salpingectomies are a problem and they are nidus of infection. They could lead to abscess formation later also. So, ideal would be to, I agree with Alka madam.
And taking the concept to remove somebody's tube, especially in an infertile patient, it may invite a lot of medico-legal. So you have to be really
proper consent
and counseling of the patient.
Madhuri, if you go to the statistics, which I told I will not go into detail.
So
when you do salpingectomy, the pregnancy rate is 37 to 42%. When clipping is done and it refills, pregnancy rate drops. When aspiration is done and when it refills, pregnancy rate remains to 15%. So what I'm trying to give an idea is, it is not between ART. The problem was she had a laparotomy, that is why she has frozen pelvis.
Yes. That's what, if it is free, I think salpingectomy is the best treatment. But probably when there is a frozen pelvis, it's best to at least disconnect.
Call a laparoscopic surgeon. You people make so much of money and lab people are roaming around here and there with their equipment. So call them for removing the tube.
No, but this patient was very bad, madam, and that's the reason probably the
I'm just joking.
surgeons did not really.
I mean, technical issues should not be in the city of Bangalore where you and Hema and Vidya kind of people are around.
Actually, we also did the disconnection. It was very difficult. We had to really dissect up the bowel and the omentum.
And thirdly, I would like to say now everybody, and there is a literature also that C ovary originates from the tube. So if you are at all doing well, leave those tubes.
Yeah, so it's like removing a rotten apple from the page. Better to remove it. That is the principle, and at least disconnect it totally. And then the clipping seems to be okay, an option, but better think of better things.
This word clipping has led to a lot of confusion. I tell you in practice.
Yeah, sure.
Disconnection.
And then this case, Madhuri says the semen analysis was normal, but all these array of things, and finally she suggested oocyte donation, and the patient says no oocyte donation. She said no clipping and no oocyte donation. Now this is a case of repeated endometrioma, so IVF is there. How would you proceed with the treatment? Is it a contraindication to IVF? Because you're left with very little choice now, because oocyte donation she doesn't want, clipping she doesn't want anything. She wants a baby.
Same, I think so. We are having this interaction in COVID times. There's so many people who don't listen to us.
Yeah.
And I have almost a PhD in COVID now. So when patients are not listening to you and not understanding, you have to softly find out between patient, mother-in-law and husband who is important. So you have to tell that if you want any point at the person who is important. If you want a pregnancy, then removing the tube will give you highest chance. Rest, you point to the patient, otherwise it is your choice. In 2 minutes, they all will say, okay, whatever you think best is probably you go ahead and do. And then go for a good ART because it will really give good result.
Yeah.
No, the question asked is if AMH is lower, would you go for ovum donation? I would like to make a statement. Don't go always and 100% on one report. You will see low AMH also they conceive. So we have to see the situation in toto. Give a trial of stimulation. Many times you will get. Don't jump onto ovum donation. That is my
Yes, I totally agree with you. I mean, I think that should be a last resort.
The AMH is 3.8, so that is not a problem.
Yeah, there was already somebody in the audience who asked, how does endometriosis cause infertility? So I think everything has been well listed out here. We already had discussed the issue about infections, hydrosalpingo, and in addition, bad quality oocytes, poor embryogenesis, bad embryos, everything. It is going to be.
And Hema immunological. They have immunological issues. Their pain threshold is different. Their body is different. So many of them have irritable bowel syndrome. So many things are there.
Less fertilization rate, so more ICSI, less blastocyst formation.
Their endometrium is different.
Science is very clear in endometriosis also. So that's Hema, go ahead.
Yeah, can Vidya respond to this question? Controlled ovarian, for the IVF patients, your whatever protocols do you use with or without endometriosis would be different, Vidya?
And that once again depends upon the AMH levels. Suppose the AMH is good, then I normally go in for an antagonist protocol. But if the AMH is very low, maybe we will just try a natural stimulation or an agonist protocol. If it is very low, then maybe we'll go for that. But if in this lady, the AMH is normal. So as Alka madam said, we can give her a trial of stimulation and one IVF cycle.
Yeah.
Hema, incidentally, being an ISAR president, we are having so much of discussion on this subject. And all the leading ART people are very clear that the long protocol which was supposed to be useful. In endometriosis, in fact, they started presuming that, you will give a ultra protocol. But there is very clear that if for AMH, AFC is acceptable, then still the long protocol gives you highest amount of M2 oocytes and better embryo. However, what Vidya is telling is, if the AMH is not that good, don't go for exorbitantly high dose. You can go for an antagonist protocol. There is no problem. But now, if you just understand the word antagonist stimulation protocol, antagonist stimulates nothing. So the word is only wrong. Antagonist stimulation protocol. Antagonist presses the LH. So it is not a protocol. Antagonist is only a drug given so that you are not compromising the ovarian reserve. So that you can start with. So normally, if it is a reasonable, decent endometriosis, the right thing is you give a depot on day 2 of the previous cycle. Then on day 2, you take her up for stimulation with HMG, whatever you want, you will get good success. If the AMH is low, then you will probably not give. They give, in fact, estrogen or testosterone, a little bit of thing for 16 days prior. Then start with the gonadotropin and then give the antagonist protocol. And then you expect to pool the embryos for 2 cycles or 3 cycle, and that is what gives the best results.
Hema, I would like to add something to this.
Yes.
Yeah. So according to most of the studies, and even in my experience, what I have seen, if you have a patient of endometriosis, which is so severe, it is usually 3 months you give depot preparations and then do an IVF. This really improves the results because you're decreasing the toxicity of endometriosis, because there are a lot of immune reaction, that is the cytokines and interleukins which are involved. And it also improves the endometrial receptivity. And if you're talking even about patients with poor ovarian reserve, like this patient was having good ovarian reserve. So now there are so many studies which have been published, and what they have said that in a poor patient with poor ovarian reserve, you can use both antagonist and agonist protocol. But what is said that the long agonist protocol is much better, though you might require a higher dose of gonadotropins that should be used. And that is because you get a uniform cohort of follicles, because when you're doing an antagonist protocol, you don't have a uniform cohort of follicles. And the number of oocytes, what you get is, the M2 oocytes you get is much less as compared to an agonist protocol. And it has also been seen that the clinical pregnancy rate and the live birth rate is much higher, even in a patient of poor ovarian reserve, where you're using a long agonist protocol instead of an antagonist protocol. So initially we moved from the short, otherwise we were using the short agonist protocol, but short agonist protocol has the lowest pregnancy rates because there are always chances of having a premature LH surge when you're using a short agonist protocol, because it causes flare for the first 3 days and then only it suppresses. And this flare can result in rise in the progesterone levels and therefore decrease in the pregnancy rates. So therefore, the long agonist and the antagonist protocol are good. Of this, the long agonist protocol is much better today, what it's described according to the evidence, and it has a grade B evidence.
Okay, one last closing round of...
One small thing.
Yeah.
Me, Alka, and I think so, we all were on the same subject. And I remember Pratap was asked to only speak on impact on fertility and abortion. And what Madhuri pointed out, that this depot had, if endometriosis ultimately leads to a lot of inflammation, adhesion, and toxicity. So when they are suppressed properly, the entire that inflammatory part really goes down, and that improves the oocyte quality. In fact, our friend Sudha Prasad of IHR, whichever the good organization is, she was telling that she had noticed occasionally that after a good endometriosis surgery, and I was very happy she told good endometriosis surgery, there's a transient rise in AMH, transient rise, that is because the inflammation goes down. This is only a transient rise, which is not an actual rise, but I think the point Madhuri is making is clear.
One last closing round of questions to everybody. You see, whatever protocols you use, it is a given that with endometriosis, the oocyte quality will be suboptimal, the embryos will also have some poor survival, they're of poor quality, this, that, and the other. So my answers from everybody, what I want is blastocyst transfer a good option to select the best embryos? Prakash.
100%.
Yeah, Alkaji.
Ixiom blastocyst.
100%. Madhuri.
Yes, if you have more number of good embryos on day 3, then probably blastocyst transfer is the best. But if you just have 2 embryos and they're not of grade 1, they're grade 2 or grade 3, then it's better to put these embryos inside on grade 3, because many a times you'll just not have an embryo to be transferred on day 5.
I think the question should be whether it should be fresh or frozen in endometriosis, how it makes a difference.
It should be fresh, because the embryo quality is not good. So if you freeze the embryos, it's again going to deteriorate, because you're freezing. There's always some amount of epigenetic and other damages which happen because of freezing and thawing. So it's preferable to do a fresh embryo transfer.
So Vidya also agrees?
Yeah, only, see, when we have less embryos, then there are no chances of it going to blastocyst. It may not go also. So that time day 3 transfer would be better. But if we have many, then day 5 is always the best.
So that is what actually what we were trying to highlight was that when you give a different protocol of suppression, the option is given to the patient that you will have 2 stimulated cycle, not 1. And you will actually pool those 2-3 embryos, not immediately 1, give her the best possible result. You will have higher dose, lesser number of oocyte, but most of the thing what we discuss is totally...
Prakash, nowadays for endometriosis, pooled embryos should not be done.
No.
Why? Please let us know.
Yeah, because what happens is when you're pooling, I mean, there's always some amount of cryo damage which is there. So only when you have too many embryos, it's best that you can freeze them, and then probably you can do a frozen embryo transfer. But when you have less number of embryos, it's been shown that many a times when you want to, you freeze, you just got 1 or 2 embryos, you freeze them. And then when you're stimulating again, there's no guarantee that you're going to get, especially in poor ovarian reserve.
But Madhuri, this stands for every IVF. Like nowadays, there are people who have totally gone into frozen.
But they have just seen 1 or 2 papers and they are going and doing it. So if you look at the larger evidence all over the world, it says that freeze in indicated cases. It's not freeze for all. So that's a very important thing.
I will just add, Madhuri.
We have to freeze the. We may have to freeze the.
Yeah, Hema, I will have to add. I was sitting with Jatin, Firuza, Nalini Majan, X, Y, Z. You name so many people.
The who is who.
Now, what they were trying to give an idea is, you consider a bad endometriosis, which may be a poor responder, and then you treat it in that fashion. And in those situations, you have given a promise that you will have at least 3-4 embryos preferably, rather than only jump on 1 IVF. And then you treat almost like a poor responder. And if there are 4 or 5 embryos, then only you will think of blastocyst. Otherwise, you cannot think of blastocyst.
No, but Prakash, even the Cochrane review says that it's best to do a fresh embryo transfer in patients with endometriosis, rather than doing pooling of the cycles, because there is no guarantee, because the freezing and the thawing, there are certain people who are doing, because there were few papers which were published which said that freeze for all and you get better. But it does not.
Come on, Prakash, you are a good debater. I'm enjoying.
No. Very important point, Madhuri. What is the point is, it is not that you're not doing a fresh transfer. You are stimulating, you are having 3 oocyte, you have got 2 embryos, you can transfer 1. In now 1 cycle also we have dual stimulation, you have second. So what I'm trying to give an idea is, you will do a fresh transfer, that's not a problem, but you will have success when you have more than 1 IVF, so that you will have definitely better pool.
So you are of the opinion of freezing. Don't change your statement.
No, I have not changed. What I told is the pattern which I told.
No. You put 1 fresh one. You freeze the other 2. Correct?
No, Hema. No. I will tell you why.
No, Hema, don't try to.
No, Hema. In ART, I am more clearer than endoscopy. First point.
Madhuri is sitting there.
No, Madhuri is telling put fresh. No. You are saying put pool and freeze, frozen. That's what I want to check.
Just listen the entire thing.
Yeah.
See, I told you, if the AMH is low or AFC is low, testosterone gel, etc., is given prior, many other things to improve the response. Now she has 4 oocytes. Yes, 4 oocytes, of which there are 3 embryos. So you are not in shortage of embryo. You are still going to tell to the patient that amongst these 3, we'll transfer 1. 2, you will freeze.
Yeah.
And you will stimulate again if she doesn't conceive. Because
Madhuri is freezing.
No, not like that. See, it depends upon how many embryos you have. But what I feel, if this patient is 35 years, she's more, and her chance is less. I think if she has 3 embryos, I think at least 2 you need to transfer. In patients who are younger, you can transfer 1 and freeze the remaining. That's what everybody does. But
everybody does in COVID.
older and not chronic endometriosis, I think it's better to transfer 2 embryos.
Madhuri, everybody doing in COVID times, keep some money, standby. So after COVID times, you have enough balance left. So
actually, Prakash, you are right. Taking decisions in these procedures, whether ovum donation, whether pooling, whether multiple stimulation, money also becomes a deciding factor.
Yeah, and role of DHEA is in low AMH, DHEA.
There is no role of DHEA in low AMH at all. If at all, there is some role of testosterone which is given for 3 weeks before in the next cycle. But again, with this, you have only a 1.5%. Instead of 1 oocyte, you'll get 1.5 oocytes. But there is no increase in the live birth rate.
Madhuri, what is the dose, duration, and preparation of testosterone? Please tell for everybody's benefit.
Yeah, you get it in androgel, so you give 15 grams. It's a dermal application. It has to be given 3 weeks for 3 weeks in the previous.
Which company makes it?
Androgel is from
Androtas gel. Intas.
No, but I basically we uses from
Madhuri, the application is once a day or twice a day?
Androtas gel it is.
Once a day.
Once a day. But then that is standard.
So many patients come to me, madam, I have taken this diet and my AMH is now better. Is it possible that AMH improves?
No. Several studies were conducted, and if you look at the studies in chronological order, there were only 2 papers, and they were basically only by Gleischer et al., who showed that there was increase in the AMH. After that, whatever papers were published by Wild and the other, there is no increase in the AMH values. And then the recent Cochrane review also said that there is really no role of androgens.
Madhuri, one last question for you from myself, Priya Mahesh again. In IVF patients who require egg donation, they have endometriotic cysts. Is it necessary to remove the cysts before IVF, or do the cysts hinder implantation?
What's the question?
If there's no symptoms, I think you should not touch the endometriotic cyst. Even if the patient is going for a fresh cycle, it's not only for donation cycles. Even if she's going for a fresh cycle, and you can you've done your transvaginal ultrasound and you can aspirate the follicles. The X-ray says that there's grade A evidence that there's no need to remove an endometrium.
Yeah.
But number of IVF colleagues send these cases to me that you would remove.
Yes, but then the most recent guidelines from X-ray, which has come out in 2018, says that there is no need to remove an endometrioma before you IVF, whatever size it is.
Alka, they send
But if they send to Alka, she has to remove, na?
No. Then they believe in it that it will improve their results.
It does not.
They want to send something to Alka wherein they are happy and Alka is happy. No. I agree with Madhuri that removal of endometrioma has no role in improving fertility when it is going through ART. Now, Hema, as you are closing, I will make a very important announcement which Alka is aware.
Please.
Next week on the same time, 26th, we have one of the biggest event which even Shubhu and all these people are knowing, wherein we have Arno Marties, we have Sanjay Patel, Alka Kriplani, Jubilee Brown, AGL president, and Pundam Baker and everybody. It's from 3 o'clock to 8:30. It's once in a lifetime opportunity. Next Friday, same time. Many things about endometriosis also, and I want Hema to also watch and ask few questions.
And Hema, I want to make a request that you are the queen in the south, so you please popularize it. We are going to put so much of he's going to put effort. So at least more and more people should know. So on
We
your
will,
social
we
platform,
will popularize in the whole of India and beyond. Nothing to
Yes.
worry. That is the credit we give to our own assets which are here.
Akash, you tell all the friends that it should be properly, popularized.
Yeah, and one last word from Caroline, who has been very patiently listening to the agreements and disagreements. Caroline, you have recognized that if you don't find the answers for us, it's going to be very tough managing this endometrium in future. So you have to do something about it in your research, okay? And also one particular question about neural endometrioma. Do you have any comments on that, Caroline?
Yeah, I agree with you about the research. I think it's really important. And I think there's, what I was trying to show in my talk is that there's a lot of new knowledge, a lot of new technologies. And I think we're really on the cusp of being able to put some of that together. And the other thing that really is needed is an early diagnostic, a non-invasive diagnostic, I think. And, hopefully some of this research might find something for that. Yeah, I was thinking about the neural endometriosis, and I was wondering what age was the woman when, or was it a man even, that got the neural endometriosis? Was it very young or
26?
26
years? Yeah.
Only thing I can think of is it could be metastatic spread, through the bloodstream. I guess, of tissue that perhaps somehow or another gets into the bloodstream during the menstruation process, and it just little fragments circulate. So it have to probably be pretty much one or two cells, and gets to the. I presume it was the brain, was it, or the brain or the spinal cord, or the only other thing. That's why I was asking about age group. Could it have been? It seems an awful long way away developmentally from where the uterus arises, where the brain does, that there could have been some kind of misplaced or maybe even a metaplasia of tissue that then has endometrial characteristics in the brain. But it's a very hard one to explain, I have to say. And so it must be very rare.
Yes, we can't figure out how it went, where it went. Yes.
No, it's really, I don't think that's a retrograde menstruation one.
And secondly, hemite is a multifactorial disease. We really don't know whether deep endometriosis and this ovarian endometrium are really the same. So there are so many things.
You are right. You've really raised an important point, and that's another aspect of our research and why we have to work so much with clinicians, because there probably are subgroups, and I think it might start to show up in some of the genetic work that may, and then with the symptoms and the location and type of endometriosis that you see, that maybe there are subtypes, because it's just so common, it's likely to be, and then once that could be identified, particularly I think from the genetic work or genomic work, then perhaps it'll be easier to understand, and then perhaps to get a better handle on how to treat as well.
Yes.
For the individual types. Yeah, we need to know a lot more, don't we?
Yes, that's what I said, that there's a lot of work cut out for you guys to tell us what we need to do move further. And Caroline, if you would have noticed, the very first video that was played was called Building Bharat. Bharat is as in India. The diversity of the thoughts that you heard from our esteemed panelists and the unity of action speaks volumes about how in our country, with all the challenges and beyond COVID that we are faced with, how women both from the rural and urban sectors are trying to reach the best of the people, the most skilled from within our own Bharat, to get the best out of them as a part of their holistic, comprehensive management of endometriosis. So once again, very humble thanks to Caroline, Alkaji, Prakash, my very, very dear Madhuri and Vidya, who have joined us, and this evening, one of the most meaningful and delightful brainstorming over the coffee which only Prakash Trivedi.
And
we all need.
One last question.
greatest
How
thanks
many
to
people logged in
Hima.
today?
वो बात की बात है.
How many people logged in?
नहीं वो आपको मालूम पड़ेगा. But Hima, I think so. You were superb in moderating. That
Thank you.
I'm working years and years. So,
Alkaji will just give you the numbers with the WhatsApp in a few seconds.
I thought everybody should know. Last time there was a huge gathering.
Yes, and I'm sure that this program would have attracted many more. You saw the questions from all over beyond India, so I think yeah.
I want to congratulate you on the whole concept and that, so that, because I noticed you had some questions from Nigeria, for example, so you are reaching out a long way.
Yes,
and what you're doing. So
yeah, I think the digital connect has really opened our eyes to how much and how far we can reach, and we are exploiting every opportunity to share and very proudly showcase our own resources from within our own country to the rest of the world. So thank you very, very much for this collaborative event brought to you by artists and the Bharat Serum, and of course Subbu and his team from Science Integra. We're ever grateful to you for a seamless transmission. And all our delegates, join us again month after month for the Knowledge Cafes. You will have more stimulating effect to your brain with all the.
And on behalf of everybody, excellent moderation. You didn't let anybody fight.
Thank you very much.
Thank you.
Bye-bye.
Bye.